Dr. Paul Whelton is one of the most influential living hypertension physician and researcher. He has led several major trials, most famously the SPRINT trial and ALLHAT trial. He chaired the 2017 ECC AHA Hypertension Guidelines Writing Committee, and he's the former president of World Hypertension League. Dr. Paul, thank you very much for accepting the invitation. It's an honor to have you.
It is my great pleasure and privilege. And of course, it's lovely to be connecting with colleagues in your part of the world where I've spent many years and have so many good friends.
Thank you very much. Hypertension impacts 1.4 billion people around the world and kills many million each year. It's a very complicated disease and the diagnosis can be challenging at times. My first question is, which blood pressure reading do you rely on to establish the diagnosis of hypertension? Do you rely on office reading or home reading or 24-hour blood pressure reading, especially that many times they can vary?
So let's keep it simple. First off, hypertension is an arbitrary, is something arbitrary. We just made it up. The body has no hypertension receptors. The body responds to level of blood pressure. And level of blood pressure is in isolated societies where they have no access to televisions or cars or salt or any of those things. Blood pressure, it remains relatively low throughout life, 90 to 100 millimeters of mercury. So that's probably what the body really wants. When we look at kids, we have a study here in Louisiana called the Bogalusa Heart Study. It's a very famous study. It's a biracial group of about 9,000 kids. We followed them for many years, and now much of the research we're doing is around Alzheimer's because the original cohort is old. But in those kids, even when they are preteen, very young children, if they die and they have an autopsy, we see signs of early atherosclerosis. There was a very famous study done here in New Orleans called Payday, a histologic study looking at young kids. Again, very high prevalence of these atherosclerotic markers, the fatty streaks. During the Korean War, the Vietnamese War, young men who were in the army were autopsied. Same thing, more advanced. So we know atherosclerosis occurs early in life. And why is it occurring? Because their pressures are higher. They've got other risk factors as well. So we have a huge epidemic. And, you know, where we would like to be is much lower level of blood pressure. So where do we start to intervene? Well, we come up with the term hypertension. It's okay, it's fine. It's an operational term, but it's changed over the years. When I started, it was 100+ year age systolic. You know, then it's sort of people latched on to 140/90. I can tell you right now, our group, we do global estimates, and I think, without boasting, we do the most careful global estimates. We have the most recently just published we've done it 2000, 2010, 2020. In the 2020, we had about 360 some true population estimates, and that's applied then to census data to get how many people. Well, I can tell you at the 140/90, which is not what any guideline is recommending. We're recommending in many guidelines, we're not what all guidelines are recommending. In the US, we recommend a cut point of 130/80. But even if you take 140/90, globally, that's about 1.7 billion people. If you were to look at 130/80, it's about 2.6 billion people. So it's huge, even with the definition of hypertension.
Yeah.
How do we recognize it? Well, I think keep it simple. Let's not get complicated. Office blood pressures are the sort of benchmark or the hallmark. They are traditionally what we've used to estimate risk. They are certainly what we've used in every major trial. So I would say, you know, that has to be the most important one. Has to be done properly. We do office blood pressure measurements in routine clinical practice terribly. It's shocking. We're very careful about laboratory measurements. You know, we have all kinds of attention to detail. And if the lab isn't doing it with attention to detail, that lab is closed down in almost any country. On the other hand, we permit horrible measurements of blood pressure in clinical practice. So, and if you're not getting an accurate blood pressure measurement, you're flying blind. You have no idea what you're really doing in practice. So it's pretty shocking. That is probably the dirtiest, dirty secret of clinical practice. And it's not confined to any country, it's worldwide. We just do them, and we don't teach people how to do them properly, even in medical school. We just assume this is something you can do. It's passed on from one person to the next, and what's passed on is very poor practice. So the key to getting accurate blood pressure measurements, and we know there's a lot of variability in blood pressure. It's been shown over many years, and we know the causes of the variability. So there's some things that predictably will result in a higher pressure, some things that will predictably result in a lower than the true blood pressure in your measurement. And there's a lot of random day-to-day variability.
Yes.
So how do we deal with that? Well, the first thing is to have somebody rest. When they come in off the street, their heart is racing, they're anxious. They hear the doctor coming down, or whoever is measuring the blood pressure. If they're wearing leather shoes, they hear him coming down the corridor. I can tell you as a patient, I know this. I've sat in there. So they need a period of quiet rest. Now, how long? We recommend 5 minutes in the US, but I think even a minute or two is pretty good at getting people more settled. Secondly, the measurement itself needs to be done accurately. So the actual device should be a clinically valid device. And there are a lot of websites that tell you how to choose it. In the US, we have BP-Val. In Europe, they use Stride. And unfortunately, the manufacturers use different names and different nomenclature for the devices in different countries. It's shocking, but that's it. That's the way it is. So in the US, I could go to Stride and it would make no sense to me because it doesn't reflect well what's being sold in the US. BP-Val does. So you have to find what is a website that tells you which instruments are worth buying. Most instruments that are sold in e-commerce over Amazon or other sites, they're not clinically valid. They've never been validated. 95% of them. They're usually cheap and they're not very good. So that's a starting point. Secondly, then, the person needs to be in a nice quiet area, a little bit of rest. You need to apply the correct cuff. A cuff that's too small is going to get very high pressures. A cuff that's too large is going to record pressures that are lower than the average. So the right type of cuff, then getting at least 3 measures that are separated by at least 1 minute. And I would say for most people who are used to getting blood pressure measurements, I average the 3. If they really walk in off the street, you can discount the first measure because they're still revved up from being in the street and anxious about having this blood pressure measurement. So many sites recommend not using the first measure, but if they're used to blood pressure measurements, use all 3 because that will, when you average, you tend to deal with random variation. So those are useful ways to get at an accurate blood pressure measurement. Then you use whatever you think is the appropriate cut point. In the US, we're at a point where we would say 130/80 is at least where we would intervene with drugs. Not in everybody, but in those who are at high cardiovascular risk. Other countries, they're sticking with 140/90. Crazily, those countries almost all recommend treating to 130/80. So that makes no sense to me. If you think treatment to 130/80 is appropriate, why would you not diagnose at 130/80? But our biggest problem is we don't diagnose properly at all, and we don't really treat at all. So that's a much bigger problem. Accurate measurement is very important. And I would say the office measurement is the core. It is important really if you can, and if you have a patient who is capable of getting outside blood pressure measurements because it's true that in office settings you can get inaccurate measurements. Typically, the pressure is too high. It's too high by about 7 millimeters on average. Can be more than that. It can be, of course, too low, but typically it's too high. So you'll overestimate the diagnosis of hypertension. Now, how do you get an outside measure? Well, I think the only realistic way to do it is home blood pressure measurement. That means helping the patient to buy a clinically valid blood pressure measurement device, training that person how to measure blood pressure properly. There are lots of training sites. You can get them on the web. I will tell you one that I think is particularly nice and very simple, and you can get it on the World Hypertension League website. We did it with PAHO. And it's a really simple stick approach, and it trains and certifies people for office blood pressure measurement and for home blood pressure measurement. So that's the first part. You need to be equipped to get accurate blood pressure measurements. I think ambulatory blood pressure monitoring is not very available. It is expensive. It's okay. It's better than anything else, but it's just not realistic in most parts of the world. Certainly in the U.S., you get paid for it, but what you get paid for it doesn't pay for the cost. So most clinicians don't use it, and patients are only going to do it once with the devices that we have, the typical devices we have now, because particularly if you're using it at nighttime, it's very
Yeah.
disruptive and annoying. So office blood pressure measurement is, I think, the core, supplemented where feasible by home blood pressure measurements.
Yes.
Ambulatory blood pressure measurement, wonderful, but not very realistic. If your cut point is 130/80, it is identical for office, home, and daytime ambulatory blood pressure monitoring. If your cut point is 140/90, it is going to be a little bit lower for home blood pressure and for ambulatory. Typically, if it's 140/90 for the office, it's going to be about 135 or thereabouts for the pressures outside the home. So that's a starting point, and I wish we could get accurate blood pressure measurements in practice. It's been difficult, and maybe in the future we will have easier ways to measure blood pressure and better ways like wearable devices,
Yes.
rings and watches and so on. Right now, not a single one of those is clinically valid. So they're highly promoted. There's money in it for Apple. There's money in it for all the companies that are selling you rings and watches and so on to measure blood pressure. They're not accurate. I would not use them for that purpose.
Yes. You just talked about office blood pressure, and you said that they should rest for 5 minutes. Or wouldn't it make sense that if someone sat for 5 minutes and resting and in a quiet room, how they recommended, that wouldn't be realistic how life is. Life is very noisy. You're
Right.
driving, you're active, and
Right.
if you're stressed in the hospital while you're walking, you probably are also elevated during work, while you're driving, while you're in the mall. And wouldn't it be also an alarming sign if someone just by talking, their blood pressure would go up?
Yes, you're absolutely right. When you do what I recommended, it is what we would call a basal blood pressure.
Hmm.
Or Smirk was a physician in New Zealand, and many people call it the Smirk blood pressure. It's standardized. From one visit to the next, you can compare these blood pressures. So it gives you a standard average of blood pressure. What you're looking for with these measurements is what is the person's usual blood pressure.
Hmm.
Give you a standard approach. You're right, of course, that they may have higher pressures when they get subjected to the stresses of life.
Yeah.
That is quite correct. But we base our risk estimates on that type of blood pressure measurement. That is what has been used in all the cohort studies. That is what has been used in all of the trials. So if you want to practice so-called evidence-based medicine, that is the type of blood pressure to measure. But you're correct that Blood pressure is influenced by many things, and that basal blood pressure may not be the common pressure that a person would be exposed to. When we get to the point that it is realistic and feasible and economically sensible to be doing using these wearable devices and so on, that will give us a much better picture.
Yes.
Right now, when we use these devices we have now, like a watch, they're not clinically valid. And when people go out and swing their arms, they're okay. Some of them have been validated with their arms at rest, just like we validate the upper arm cuff.
Yeah.
But when they go out and they start swinging their arms and they're walking and they're running and so on, they're totally off the charts.
Mhm.
So we still have challenges remaining for getting the optimal approach to blood pressure measurement. At the moment, we recommend this sort of basal blood pressure measurement. It is what's been used for risk predicting in all the cohorts, and it's been used in all the trials. So that's why we recommend it.
Some people would have higher response to spike of blood pressure by smaller stress, even by just talking,
Yep.
and
Yep.
others would not have any response, any spike in blood pressure from stressors. It seems like the response to stress is different from person to person. Would that be related to the sympathetic nervous system, or what would cause that? And is there a solution to that?
Right. Well, we know some of the things that result in higher and lower pressures. So as you mentioned, talking, crossing your legs, all these sorts of things will lead to a higher pressure. So when we're making these recommendations, we recommend that somebody is not only resting for some period of time. 5 minutes is perfect, but if you can't do that for at least 1 or 2 minutes, we strongly recommend that they should be sitting in a chair with an upright back,
Yep.
their feet flat on the ground, not crossed. No talking during the blood pressure measurement. And you know what happens when you go in? When I go in to have my pressure measurement, what happens? They put me up on a couch. Absolutely wrong. My feet are dangling. I take no notice of that measure. The nurse or the tech or the physician comes in, they slap a cuff on you. They talk through the entire measurement.
Yes.
They're doing the measurement, they're
Asking
measuring,
you
they're listening to your heart rate. So,
question.
that is the typical measurement, sadly, in clinical practice. It is horrible. It is,
Mhm.
and it's going to get inaccurate blood pressure measurements.
Yes.
There's no way around it.
Yes, first reading that is elevated, or just by simple task that it gets elevated, or white coat hypertension, wouldn't that also be an alarming sign, or pre-hypertension? Because that also, some trials showed that it can cause some damage, like the Pamela study, for example. They showed that white coat hypertension can cause damage, not as much as hypertension, but also not as normal or baseline.
So we have two types. We have three types really of blood pressure. If we were to compare office measurements done properly to out of office, let's say a home blood pressure done properly, there are a couple of possibilities. One possibility is you're low in both, and you
Yes,
can be pretty sure at that point you do not have what we classify as hypertension.
that's the best.
Doesn't mean your pressure isn't higher than is desirable, but you don't meet our magic cut point.
Yes,
You can be high in both, what we call sustained hypertension. You can be pretty much 100% sure now your pressure is too high. It's well documented. You can be high in the office, but not high outside, and that
yes,
would be white coat hypertension. The people with white coat hypertension have a risk in almost every cohort that is very similar to those who are not hypertensive. So it has minimal additional risk. Now, about 2 to 3% of them every year will graduate to the class of hypertension. So you need to monitor them very carefully because they are giving you a signal that there's something starting. But the risk is not really very high. It's certainly not high enough to warrant recommendation for antihypertensive drug therapy in any guideline. The contrary to this is people who are identified as not being hypertensive in the office, but are identified as being hypertensive out of the office. Typically, they are close to the cut point for hypertension in the office. That's called masked hypertension. Those people have a risk that is almost identical to sustained hypertension. And there are no clinical trials of treatment done in that group, but every guideline that I'm aware of says, based on risk and what we anticipate from treatment, that adding antihypertensive agents to non-pharm in that context is desirable. So those are the four sort of classes or categories of blood pressure we get by comparing office to out of office blood pressure measurements.
One of the things that confuses me that guideline mentions that they rely on office reading to diagnose hypertension, but if someone has high reading at the office and normal reading at home, is he hypertensive or is he white coat hypertension?
White
Because
coat.
yeah,
White coat, and
so then you
just
need the
about
home measurement to diagnose hypertension in a way to
yes.
support the diagnosis.
When we wrote our 2017 American College of Cardiology, American Heart Association guideline in the US that I chaired, it was the first guideline to say you in the US, and this was directed at the US population, you should confirm the diagnosis of hypertension by getting pressures outside. And we can do that in the US. We're, higher income. We're at a different stage in our journey to the management of high blood pressure than some other countries. It's not as realistic in many of the countries that I have worked in through my own activities and through the World Hypertension League. It's just not realistic. So if it's feasible to get accurate measurements in the office and out of office, that is highly desirable. You're absolutely correct.
So would you say it's fair to say screening hypertension is done in the office and confirming the diagnosis is at home?
That would be the best, and that's what we would recommend in the US. There are other guidelines. The European guidelines generally will say either confirming it with a second set of measurements in the office or confirming it out of office.
Mhm.
But you're right. I mean, the best, of course, is confirming it out of office
Yes.
because that's the only way you can get at things like white coat hypertension and masked hypertension and some other characteristics of individuals as well.
Yeah.
There are lots of things we'd love to have. In the world, there are things you'd like to have, and there are things you must have. So, would we like to have nighttime blood pressures in everybody? Yes, of course. That is the best risk predictor we have.
Yes.
Is it realistic, feasible, affordable, etc.? No, it's not. Even in a high-income country like the US, we generally don't do that. We use a surrogate. We say to people, get your blood pressure measurements at home, and when you're taking them in the morning, get 3 well-measured readings before you take your medications. And that's going to give us some window of whether the treatment they're on is controlling their blood pressure as they are going from nighttime into early morning time. So we try to do it in a surrogate fashion.
Mhm.
There are lots of things we would like, and we just, at the moment have to say what's realistic and what is
Hopefully
absolutely
soon as
required.
things progress. Yes.
Yes, I think measurement of blood pressure is an area where we're moving quickly, and I
Yes.
am confident that at some point we will have wearable devices that will be clinically accurate, and that will give us a huge window on a lot more observations. So you get rid of the random variation, and it'll give us observations into the evening as well as during the daytime. So we will be better equipped as clinicians.
If someone has office reading of 140 over 90, and then the second reading would be 130 over 80, you give him a blood pressure machine at home, he goes and measure at home. There is a lot of normal readings, but there are some readings that are between 120 and 130. Is that hypertensive patient? Is that white coat hypertension? What should this person do? How often should he measure?
I think the important thing is never rely on a single blood pressure measurement.
Yes.
We know that there's a lot of random variation, and it's bigger for some other things, but it's much less for other things. So you weigh your weight in the morning, and you know from day to day you get crazy stuff. I am, every morning I weigh myself. Well, I get variation from day to
Yes.
day.
Yes.
I will tell you, weight does not randomly vary anything like as frequently as blood pressure. So when you measure blood pressure, it's up and it's down. And by chance, you may get a high pressure, you may get a low pressure. What you want is you've not only got to do it as accurately as possible, but you've got to average over several blood pressure measurements. So I would say averages either in the office or averages at home are very important because what you're trying to get at is a person's usual blood pressure measurement. That is the important predictor. People get all excited about the importance of variation in blood pressure. And statistically, it is associated with risk. But I can tell you, in terms of importance clinically, very little. We have fancy statistical ways for looking at this, and I've done that. And almost every cohort I've been in, we can associate the degree of variability in blood pressure to risk.
Yep.
But when we look at its net contribution clinically to the importance, putting that into a risk predictor, it is of very little importance. So the average blood pressure is incredibly important. And systolic, obviously, is a much more important risk predictor, especially as you get older. That is, I think you could reasonably say if you're using 130 over 80, for sure, you could say track systolic. Forget about the diastolic.
That is
If you want to
office
be
or
careful.
home? You're talking 130?
Doesn't matter. Doesn't matter. Risk, the prediction is really primarily systolic. We've shown that when I started in my research career, I showed that in kidney disease. It's been shown for myocardial infarction, heart failure, kidney disease, brain, etc. That really there is an incremental impact of higher diastolic. But the big incremental impact is with systolic. And if you put the two together, you get some independent contribution of both. But generally speaking, systolic is going to be the one that is going to predominate the risk prediction.
When you say, the reason I'm asking, because many people categorize in this category, they would have their office blood pressure is 135 or 140, the first reading, especially, always the first reading. And they will not go to normal reading in the second reading. It might go a little bit lower, but it will never go to baseline in office. But then when they measure it at home, where it's more relaxing, they might get normal reading, but they might also get a lot of reading between 120 and
Yeah.
130. And this is a very gray area where you don't know whether they're those
If in
hypertension.
doubt, treat. If in doubt, treat, I would say, because you know what? Our body likes 100 millimeters of mercury.
Yes.
That's what people in isolated settings live on. My son, I have two children, they're both cardiologists. My son is at Johns Hopkins. He was trained by the people that I trained, sort of interesting. And he did a study, I had nothing to do with it, but it's a very interesting study. He took a cohort called MESA, and he got a group of people who were at low cardiovascular risk. They were low cardiovascular risk. I'll stress that. And he took a group of people with an average systolic between 90 millimeters and 129
Yes.
and followed them over time. And what did he see? He saw that baseline blood pressure between 90 and 129 millimeters of mercury was a strong predictor. Higher the pressure, the stronger the prediction of increases in blood pressure, of the occurrence of other cardiovascular risk factors. He is especially interested in calcification. He saw a strong relationship between level of blood pressure and calcification in single vessels and what they call complex disease in multiple vessels. Calcification of the coronaries is a very good intermediate predictor of risk. It tells you you've got atherosclerosis.
Mhm.
And he saw the relationship with atherosclerotic events. So that's telling you that the body likes a much lower pressure than what we call hypertension. So if I was in doubt around the cut point, I would rather treat than not treat
Yes.
because you're not going to go very wrong. The treatment is very simple generally. It has very few side effects.
Yes.
It has a little inconvenience. It costs money, but generally these pills are pretty darn cheap,
Yes.
and lifestyles are desirable for all levels of blood pressure. So I would rather err on the side of treatment than not.
Mhm. And in the study that your son has done, the people who had systolic at 90 and 100 had lower calcification. And the more you go up in pressure, up to 129, they had higher calcification, or did I get correct?
Correct.
Yes.
Correct.
So even at
And
one, Mhm. Go ahead, please.
I'll let you into a secret. I
Mhm.
have high blood pressure. I've had it for many years. And guess what I keep my systolic blood pressure at?
What?
Less than 100.
Yes. And what's
Yeah.
and
And
what
I'm
was the
very
average?
active. I'm close to 80 and I walk, I walk at least an hour and a half a
Very
day and
fit.
I do a lot of stuff. And I'm like most people. I have very simple, easy to control blood pressure, uncomplicated. That's what 80 or 90% of people, a monkey could manage me. I'm on two meds and lifestyle,
Mhm.
and I keep my systolic under 100. Now, in the guidelines that I'm involved in, we recommend, something a little more realistic for most people. We say in the US, get your systolic under at least 130, minimally under 130. If you can get it under 120, because the trials have clearly demonstrated the benefit of getting below 130 and getting below 120.
Yes.
And when we think about risk, people tend to underestimate. So they think about, oh, okay, heart attacks, strokes, heart failure. Okay, those are really important. But there are a lot of other risks that come with high blood pressure. Obviously, as a nephrologist, one of the early things I did is look at blood pressure and its risk in kidney disease. And it's a striking relationship. If you look at brain function, whether it's cognitive impairment or dementia, especially blood pressure level in midlife is a very strong predictor of brain function later in life. If you look at things like valvular disease, aortic stenosis, aortic regurgitation, mitral, the same, blood pressure is a very important predictor. If you look at atrial fibrillation, you can
Yes.
go down the list. So blood pressure, in the trials, we're usually checking our primary outcomes are based on cardiac and brain. That's generally what we focused on. Now
Yes.
we're beginning, excuse me, cardiac and brain for a stroke.
Yes.
Now we're beginning in the trials to look at brain function,
Yes.
dementia, cognitive impairment, and so on. But there are lots of other risk
Yeah.
factors. They occur over a longer period of time, typically with lesser dramatic increases in blood pressure. We don't measure them very well in our risk predictors. We underestimate risk in risk predictors, and we don't look at them very well in our trials because they occur over too long to really see the benefits.
Yes. Let's say someone went to the clinic and saw that he has higher blood pressure, 135 over 85, and he decided to buy a blood pressure machine from the pharmacy and started to measure. Out of 100 reading, will you include the readings that he just sat down and measured the blood pressure and it was high? That should be included in the 100 reading, or a blood pressure reading that he was not rested, or he should do it always 5 minutes apart when he's rested, only those readings that he
So
needs
first
to.
off, my strong advice would be get a clinically valid device.
Yes.
That's important because most of the time you're going to be buying rubbish. What is generally sold, it's shocking. Here in the US, we have what is called FDA clearance. So you go to buy a device on Amazon and it says it's FDA cleared. Now, when I hear those terms, I think, well, it must be good because the FDA has cleared it. But that terminology means very little. It means that technically the parts work. It doesn't mean the device is any good. So you have to go in the US to our website, which is BPVal. and look in there and look at my device. Has it been clinically validated? Do I know this is a good device for really accurately measuring blood pressure? So before you waste money, the first thing is make sure you're buying a clinically valid device.
Mhm.
The second thing is make sure you know how to use it. Get trained. And as I said, go to the World Hypertension League website or some other places to get uh, trained. If you can do both of those things, then measure blood pressure the way it is supposed to be measured and average your measurements. That's going to give you the best estimate of your true usual blood pressure measurement. And that's what we use when we do our risk predicting from the cohort studies. And that's what we use when we do our clinical trials. So that's the best way to go about it.
Do you include the first blood pressure reading in normal setting?
For people who are used to blood pressure measurements, they're past the nervousness of getting a cuff put
Yeah.
on them and so on. Yes, I would use them. If you look at, we have a study in the US, a very nice one called NHANES, and it's done every year and it's published biannually.
Yes.
And it's like the patient, the general population's patient. So it does surveys and it tells us, well, what's the average blood pressure? What's the range? How many people are being treated? How well are they being treated? And so on. And so it's like your patient. The population is your patient. In that one, they recommend if you're going to use our data, they do 3 blood pressure measurements. They do them very carefully. They say, well, drop the first one and average the last 2. In fact, if you look in that database, there's no difference between the first and the second or the first and the third. And most researchers will average all 3 to get a better handle on random variation because the people who are having their blood pressure measurement in that study, they take their time, they tell them what they're doing, they don't just slap a cuff on. So I think it very much depends whether you're confident the first measure is going to be a real measure or whether it's just they've come off the street and they've had a cuff slapped on and you're just going to discount that measure because they're not really ready for prime time. They haven't had the couple of minutes of rest, etc. So I like to get all of my blood pressures to be meaningful and then average them. And I would say, generally speaking, going back to the days of my mentor in London, Jeffrey Rose, who did the first quantification of how much blood pressure effect do you get from these different exposures. He looked at random variation, and clearly there is more random variation between visits than within visits. Within visits, you'll capture most of it by getting 2 to 3 measures of blood pressure and averaging them. So practically speaking, that's what we recommend. In the US, we would say at least 2 measures on at least 2 occasions and average them. And that's going to give you a pretty good estimate of an individual's average blood pressure. Is it perfect? No, but it's pretty darn good. It's going to get it right in most people.
Is there any downside from treating an average blood pressure between 122, 123 to 130 systolic?
Not much. I would say not much because you're still above the most desirable level of blood pressure, but it's not what we've proven in the clinical trials to this point. We have lots of different trials that have done different things. If you go to answer the question of what is the desirable target for blood pressure, if you go to the best trials, the gold standard trials, they would be the trials that have randomized to different levels of blood pressure.
Mm-hmm.
Well, we've had those trials over many years, but for looking at the goals that we are most interested in these days, the 130s, 120s, etc., Sprint was probably the trial that really started to look at this carefully. So in Sprint, we said, okay, we think maybe a lower pressure than what we're recommending in our guidelines might be better right now. We don't know for sure. So we took about 9,500 people and we said, you know what, we want to get older people in here. because those are the people who we might be most worried about taking the blood pressure down dramatically. So we want older people. We want, in the US, blacks and whites, because blacks have a disproportionately high risk for any level of blood pressure. We want people with kidney disease. We're going to exclude diabetics and strokes because they're being looked at in other similar trials. So that's what we did in Sprint. And we said it's going to be really simple. We're not going to do anything fancy. We're going to randomize to two targets. In one target, we're going to try to get to a systolic of 120 or less. We know we're not going to get that in everybody, but on average, we want to get below 120 in that group. And in the other group, we're going to follow what was then the current recommendation. We're going to shoot for 140. And again, we know that not everybody is going to be below 140. Some are going to be above, but on average, we want about 140. So after 6 months of treatment, because you've got to titrate the treatment, in the intensive treatment arm, our average for systolic during the trial was about 119 millimeters of mercury. So we're absolutely where we wanted to be. And it was consistent throughout follow-up. And on the top side, it was about 139 millimeters of mercury. So we were perfect in what we wanted to get. And we're sailing along, and we said, what we'll look at? Well, we'll look at a couple of things. We'll look at cardiovascular outcomes. What's the effect on stroke, coronary heart disease, heart failure? We also want to look at brain function. So we want to look at cognitive impairment and dementia, and we spent a lot of effort trying to look at those carefully. We want to look at kidney disease. And we sort of know that things like dementia and kidney disease events are going to occur later than the typical cardiovascular events. So it'll take a couple more years before we'll be able to address them. Well, lo and behold, I was chair of the study.
Mm-hmm.
I'm driving to the airport to go overseas, and I get a call, and they say, "Where are you?" I said, "I'm driving to the airport. Please pull over to the side." So I do, and they say, "The trial has been stopped early. We're only 3 years into this trial, and it's been stopped." And they say, "Well, the difference in outcome between the two is really dramatic. I mean, it's big." So yes, it was stopped because there was a very big benefit from the people who were randomized to the lower pressures. A big benefit in terms of coronary disease, a big benefit in terms of especially heart failure. And we had, as I mentioned, a lot of older people in there. And when you have older people, then you begin to see heart failure and dementia. Those are two things that you don't see much earlier in life. You see more stroke and more heart attacks, but you especially have a big bump in heart failure and dementia. So big improvements. So
Yes.
we saw it for all of the outcomes, and we saw it for the overall composite of those outcomes. It was very striking.
Yes.
And we looked. We didn't have enough dementia events because the trial was stopped early.
Mm-hmm.
We did see differences in cognitive impairment. We saw that from about 6 months. It was very dramatic. The group that got randomized to the lower pressure had clearly better cognitive function throughout the trial. We extended follow-up after the trial and did a randomized comparison, and we saw pretty impressive trend towards a benefit for dementia. In a later trial done in China, the China Rural Hypertension Control Project, they randomized to 130 as their goal for the
Yes.
intensive group and standard care for the other group. It was a big trial with a lot of statistical power. It went longer than our trial, and they reported an improvement not only in cognitive function, but also a 15% reduction in dementia.
Mm-hmm.
Not surprising. If we know that blood pressure is a very important predictor of dementia. Is it surprising when you lower it that you get a benefit? No, but it's nice to see. Many of the other trials of the more intensive treatment trials have looked at this. They haven't done it very well. It's sort of been an afterthought. Their primary focus has been on cardiovascular disease, and they've used indicators for for cognitive function that are pretty gross. We often use in clinical practice something called a mini mental or an MMSE.
Yes.
It'll pick up gross cognitive impairment, but it's not very good for picking up early impairment. So no, none of these trials have ever shown any worsening of cognitive function in the trial, and Sprint and the Chinese trial have suggested strong benefits.
You're talking when you lower it, more significant, more aggressive lowering.
Yep. Yep.
Yeah.
More intensive lowering. So if somebody can, so what do we say in our guideline? Well, we say at least get to 130. For God's sake, get to less than 130. As pressure goes up, risk goes up.
Yeah.
Obviously, the risk is going to be
Stroke and heart,
influenced by many other risk factors. Blood pressure would be the dominant one, but your level of cholesterol, your
diabetes.
level of obesity, whether you have diabetes or not, all of these things are going to enter into the picture. The higher the pressure, these convicts all go together. So the higher any risk factor, the more you're going to get aggregation of other risk factors. Because if you go back to it, there are three legs to the atherosclerotic stool. There's diet, physical activity, and smoking. Those are the three things. Now, diet and physical activity, if they're not good, how will they manifest? Well, they'll manifest as high blood pressure, they'll manifest as a high cholesterol, they'll manifest as obesity, they'll manifest eventually as diabetes, and various toxic combinations that we call cardiometabolic disease. But those are the three things that are underpinning atherosclerotic events. And if you don't smoke and you are exercising well and your diet is healthy, you are extremely unlikely to get atherosclerotic disease. It
Hmm.
was so uncommon at the start of the 20th century that when I first went to Hopkins as a trainee, they said, go to the Welsh Library, pull out the bulletin of the Johns Hopkins Journal, and look at the report by William Osler in the early 1900s of the first case of this, a very unusual person who presented with crushing chest pain. And he was determined to have angina. That
Hmm.
was so unusual. They didn't have it.
Yeah.
And then as the country industrialized and people started using cars and elevators and
Smoking.
all the other stuff and smoking and so on, it just became so normal that it was never in grand rounds. It was the unusual that was being presented in grand rounds. So
The study that you refer to, there is like 20 million of mercury that is difference, and the Chinese one, there is 10. What about the mid-range between 120 and 130 or
any
150?
reduction in blood pressure is going to lower risk. And it
Yes.
doesn't matter how you do it. You can do it with non-pharm. We have lots of examples with non-pharm. The most recent being salt substitutes.
Hmm.
And they've been used, the trials have been done in countries with high sodium intake, most commonly in China, and especially in northern China, where there's a higher salt intake than southern China.
Hmm.
So we know from meta-analysis of the trials with salt substitutes, where you substitute typically about 20% of sodium in table salt
Yeah.
with potassium. So
Yes.
you exchange the two. When you do that in that sort of setting, you're going to get about a 7 millimeter reduction in blood
Oof,
pressure.
so
They're
much.
very,
As much
and
as
it's very
medication
simple.
nearly, right?
Yes, it's very simple. It's a
Yeah.
very simple approach. It does cost, those salts do cost more, the salt substitutes. Now, when it's been used in the clinical trials, the biggest one was the salt substitute SSASS, oh, I'll get it wrong, but it basically was a trial done in China, mostly in northern China, and it looked at people who either had a stroke or were at very high risk for a stroke. And it was a cluster design trial. So they took villages, about 600 of them, and they randomly assigned the villages to be given the salt substitute. And they said to those people, please use this salt instead of routine salt. Please do not use routine salt. They probably used it a little, but Generally, they were using the salt substitute salt. And in the other villages, they didn't give them salt substitutes. They used their regular salt.
Mhm.
They saw a lesser decrement in sodium. Typically, what you see when you use salt substitute in that sort of setting is about a 20% increase in potassium, about a 20% reduction in sodium, about 7 millimeters. In the trial, they saw about 5 millimeters. Well, that was enough to have a very strong, statistically significant improvement in their primary outcome, which was stroke. It was down 14%.
Wow.
They also saw strong benefits in the secondary outcome. Coronary heart disease was down 13%. Cardiovascular mortality was down 12%. So very impressive.
Yes.
Now, those salt substitutes wouldn't work as well in a country like the US, where most people are buying processed foods,
Yes, I wanted to.
because that's where the salt is.
Yes.
The natural foods don't have much salt. They have a lot of potassium. The manufacturers get at it and they put in salt and the potassium leaches out. So in a setting where somebody is taking their meals from home, either they're eating them at home or they're being prepared at home, and they're using natural products, not packaged and processed foods to develop those meals, salt substitutes are very, very effective.
Yes.
But on the blood pressure side, you go up in pressure, the risk goes up. On the clinical trial side, what we've been able to show is you go down in pressure, the risk goes down. The biggest increment, of course, whether it's on the observational side of risk or on the treatment side, is getting from a very high pressure down to a lower pressure. So getting from a very high pressure down to 140 will get you a lot of benefit.
Yes.
It will really get rid of a lot of the worst risk exposure. Go further to 130, yeah, you're still going to get a lot of benefit. Go to 120, you're going to get incremental benefit. It's not going to be as great. The relative improvement to risk is going to be identical across all of those observations.
What's the
The
ideal
absolute,
systolic you would say that you are
I
very
would
happy
say
to see someone in?
the ideal is get it as low as you can get it. As I
Like,
say, I keep mine under 100 because I think when I look at what is ideal from the cohorts, like the study my son did,
yeah.
100 was a very, very optimal level. When I look at isolated societies that don't get high blood pressure or don't get other risk factors and don't get atherosclerotic disease, their average systolic blood pressure is typically around 90 to 100
And
millimeters of
if
mercury.
someone is asymptomatic, and what is the level that you will start to get concerned that maybe his blood pressure is lower too much? Is it below 90, below?
Well, I would say, in our guidelines, what do we recommend? We're realists in guidelines, and we say what is proven. So from our clinical trials, what is proven without a shadow of doubt is below 130. Every guideline that I'm aware of around the world
No,
recommends less than 130.
no, I meant when do you get concerned that you lowered it too aggressively
Okay,
and in an
I'm get,
asymptomatic person?
I'm getting there. So every guideline would say on average, if you can do it without complications, below 130.
Hmm.
In the US, we say below 130, and you know what? If you can get to below 120, that's even better. Now, most people have what I call uncomplicated high blood pressure. You can put the term hypertension on it if you want. They don't have symptoms, and you treat them, and they don't have symptoms from treatment. Our treatments are very symptom free. In fact, you can show that people are better with treatment than without. Does it mean that there is never a side effect, especially from drugs? No. Some people, of course, will have some side effect. Most of the time, when people go to their physician and say, I have a side effect, it's not actually from the medication. People have a lot of
Other
complaints,
medications and other things.
usually minor, but they're typically unrelated to the medication. I'm not saying that nobody gets sick. I'm saying that When we do trials, we've done many of these now where we have trained somebody who is not a physician to manage blood pressure, diagnosis and management with medications. It's almost in all countries, legally, it is under the supervision of a physician. When we compare that approach in randomized controlled trials, a so-called team-based approach, to the traditional model of the physician taking care of the patient directly, the team-based care wins every single time, and they usually win hands down. And why is that? Well, it's because they're not doing anything else. They're trained and they follow very simple algorithms, how to do it. And here is the approach. For this level of blood pressure, you add these two drugs. When the pressure still remains high, you add a third drug. They follow that algorithm very carefully. The clinician, on the other hand, is really busy. We're stretched. We're trying to do 15 guidelines. And in the middle of the consultation, you're being called. There's some drama going on somewhere else.
Yes.
And you talk with the patient, and the patient says, doc, this has been a horrible week. All sorts of things. My mother is sick. I have problems at work. And they say, okay, let's check the blood pressure again. Let's be sure about this before we add a medication or we increase the blood pressure dosage of your medication. So we have in cohorts worldwide repeatedly seen that people get started on a medication, and typically what they're started on at the outset isn't changed or isn't changed much. So they have repeatedly high pressures to which there is no action. Now, we know, I was involved with colleagues, and Nathan Wong was the first author in a very nice paper. It was in Lancet about 9 months ago. And we pooled about 500 randomized controlled trials. They were all placebo-controlled trials. And we wanted to look at the effect of treatment on blood pressure. So we looked at monotherapy, and we found that in general, you got about 9 mmHg reduction in systolic blood pressure with a single antihypertensive agent. There was heterogeneity between the trials. We found in general that diuretics did the best. Beta blockers were the least, but they were all pretty much there around an average of about 9 mmHg of mercury. When we went to two drugs, that went to about 15 mmHg of mercury. Every time we added on a medication, we got better blood pressure control. In contrast, when we looked at going from a low dose, quarter of the standard dose, to a full dose, we saw very little blood pressure benefit. For monotherapy and dual therapy, only about 2 mmHg of systolic blood pressure. So we now know, and that wasn't a surprise, we now know that the blood pressure effect of these medications occurs at low dose.
Yes.
And there's very little benefit going to higher dose. In contrast, there are very few side effects, but they are linearly related. So when you go from lower to high dose, you get very little additional blood pressure effect. You do get more side effect. And the side effects are uncommon. And of course, idiosyncratic responses like anaphylaxis and so on are almost non-existent. So it's very safe to combine these drugs. When I started in the 1970s to treat patients with high blood pressure, the common drug that was available in the US was something called Serapis. It was put out by Ciba, who are now Novartis, and it was 3 agents together in a single pill. At that time, it was reserpine, hydralazine, and hydrochlorothiazide. We use that. People didn't fall down and drop dead and complain all the time.
And they
We have a
use
different. We've different drugs that we use these days, but we now know that it was a mistake to have gone from that approach to doing step care, which you start with one drug, you go to the full dose of that drug, then you add in the second drug, because we know when we do that, it doesn't happen. They start with one drug and they stay at one drug. In the US and NHANES, 40% of all adults with hypertension are on monotherapy. A lot of them are beta blockers. No guideline, just about no guideline recommends beta blockers as initial therapy. There might be other reasons why you would use a beta blocker, but all of the agents, beta blocker, diuretic, ACE, ARB, CCB, compared to placebo, they all lower risk, including stroke risk. When you compare those agents head to head, and we have tons of these meta-analysis, the beta blockers are terrible compared to the other agents for preventing stroke. They're not good at all. Calcium channel blocker is not good for preventing heart failure. So if you're in older people, calcium channel blockers are probably, if you had monotherapy, they would not be a good choice. But generally speaking, in our guidelines, we say keep it simple and either use a calcium channel blocker or a diuretic in combination with an ACE or an ARB. Generally speaking, I would say a diuretic, a long-acting diuretic in particular, is the best in class. If you look at these meta-analysis for overall cardiovascular protection, no matter how much people talk about metabolic changes and this and that and the other, diuretics beat everything else. But all of those agents are good. Getting the blood pressure down is the key to success, not the particular choice of drugs. So we say in most people in the US, when we look at average level of blood pressure in untreated hypertensives who are adults, it varies by age. It goes up with age, but typically it's going to be around 140, 145 millimeters of mercury. If we want to get to 130, that means you've got to get down 20 to 25 millimeters of mercury. You're not going to do that with non-pharm. You will get part of the way there. You're not going to do it with non-pharm in a single agent. It'd be very unlikely, unless somebody is really close to the cut point for the definition of hypertension. Monotherapy is not going to be sufficient. So we recommend starting with two agents in combination, preferably as a single pill combination, because that gives you much better adherence and it gets you to the goal better and just lots of reasons why. It is a little more expensive, even though in the US we now have, I think certainly more than 35 single pill combinations of dual therapy. And in most countries, there are a lot of dual therapy combinations. When we get to triple therapy, the combinations at this point are more expensive. There's no question because they're not used all that much. That's why they're more expensive. And you can either use, if somebody can afford it, a single pill combination of triple therapy is great. If they can't really afford it, if they can afford dual therapy, single pill, and add an additional agent as an individual, that's okay too. But clearly getting the blood pressure down is the key. There are some differences between those medications, but they're not that dramatic. Getting the blood pressure down, and that's best done at a low dose. So low dose single pill combinations. There's very little benefit to going to higher doses.
Yes, thank you. That's a very good recap of the treatment and all of the groups. Do you have a favorite ACE or ARB? Do you have a favorite diuretics? And do you have a favorite calcium channel blocker as well?
Well, I have a favorite diuretic, which is any long-acting diuretic. Hydrochlorothiazide, which is the most commonly used diuretic, is good, and it's been used in many of the trials, but it's not a guarantee that you're going to get 24 hours coverage with it. So I take chlorthalidone, which is a long-acting agent. In some countries, chlorthalidone is not available. Chlorthalidone has been the long-acting agent that's been used in most of the US trials. In many countries, you'll find indapamide is available and chlorthalidone is not. Indapamide has been used in several of the Australian trials. So either of those I prefer over a short-acting agent. There has been a trial, a so-called pragmatic trial done in the US that said there's no obvious difference between the two, but I think the pragmatic trials are not very good. I would still prefer a longer acting agent. When it comes to ACEs and ARBs, ACEs are probably a little better proven for cardiovascular prevention. I have colleagues who strongly prefer an ACE over an ARB. I think the ARBs are fine. There's probably less side effect with ARB. Some people with ACEs are going to get cough,
Yep.
but either of them are good. They're basically doing the same thing. They're blocking the renin-angiotensin system. So either one will work. And despite companies telling you that my particular form of ACE or ARB is superior because of this, that, and the other, and they're paying people to go out and give lectures, no. There's no evidence that any of these various types are really better than the other in clinical trials.
And you don't have a favorite one for ACE or Arabs?
I don't have a favorite one.
Mm.
I use what is well. I use what is commonly available and is inexpensive. I was on personally on an ACE for many years and it worked very well. Then post-COVID, I got what I thought was long COVID. I walked around it for a year and a half. I did multiple sputums and this and that and the other. And I saw ID, and when I saw my infectious disease consultant, the first thing she said to me is, "Look, I had had a mantle cell lymphoma. From fortunately, I got great treatment and I was so-called cured.
Congratulations.
But I was on prophylaxis at the time, and she said, "We see a lot of people just like you, and I'm going to bet you have bilateral pneumonia. You'll never get it on a sputum. You need to have a bronchoscopy." And I said, "Fine. Actually, I'm meeting with the pulmonary people next week because I also think I need a bronchoscopy."
Hopefully it will
Had a
all go well.
bronchoscopy. Guess what? I was in India and my wife called me and said, your bronchoscopist called and he wanted to talk to you and you weren't here. And he was shocked to hear that you were in India. He says, "You have H flu and you have very obvious H flu in both lobes. So get on treatment." So, yeah, at that time, because I had cough, I switched from the ACE to the ARB, just on the possibility that my cough would be due to ACE. As it turned out, it was pneumonia, not ACE at all. But I take valsartan now. It's just one that is easily available, relatively inexpensive in the US. With my insurance, when I go to get that prescription filled, I get a charge for the chlorthalidone. I get no charge for the valsartan. So, all of these sartans are pretty darn similar, and I wouldn't worry too much. In terms of CCBs, there are a lot of them out there. Amlodipine is about as good as
Yeah.
anything else. It's commonly used, commonly available. Um, and beta blockers, people keep telling you that, oh, the next generation, the third generation of beta blockers are completely different to the second generation, to the first generation. They are somehow magical. We don't have any trials with hard outcomes. When we look observationally and we do the best we can, which is imperfect, there's no evidence that these newer, more expensive, fancy third generation beta blockers are somehow magical and better. And that's my until I see the evidence, I'm not willing to jump in that bandwagon. And we don't have any evidence that these from hard outcome trials that these newer agents should be recommended as first step therapy. Is there a place for them? Yes, I think so. Now, for me, first step therapy would be combining either an ACE or an ARB with a long-acting diuretic or a CCB. If that doesn't control somebody, the second thing is to go to triple therapy, a diuretic, a CCB, and an ACE or an ARB.
Mhm.
If that's not controlling somebody, then you got to wonder, they have what we call apparent resistant hypertension. And you got to wonder then, are they really taking their medications? Are they telling you they're taking them, but they're not really? They're embarrassed to tell you that they can't afford them, or they don't want to take them, or they're just not taking them. That's the most common explanation.
Hmm.
Is there something else going on? Do they have a terrible diet? Are they taking a lot of sodium, very little potassium? Are they exercising? All those sorts of things. Do they have an underlying cause of their high blood pressure, like renal vascular disease or kidney disease in general, or maybe primary aldosteronism and so on? It's worth looking at that.
Yes.
If none of those apply and they have true resistant hypertension, then it's worth adding in a fourth agent. My preference would be a mineralocorticoid receptor antagonist. They're very good in this situation, and there is often an element of aldosteronism that doesn't really come across as a diagnosis of primary aldosteronism. Alternatively, you certainly could use a beta blocker, or you could use other agents as well. So beta blockers, they're not recommended in just about any guideline for initial therapy, certainly not as monotherapy, but they do lower blood pressure. And certainly when you combine them with other agents, you get the benefit of the other agents and you don't have to worry so much about not getting the stroke protection from the beta blocker.
Yes. I have a bit of a controversial question. Do you have any preference when it comes to long acting versus short acting? What I do sometimes is I look at the 24-hour blood pressure reading, and if someone has dipping at night, I will choose short acting in the morning. If his blood pressure is not dipping at night, I will just choose a long acting. I don't know if this is the most appropriate, but just that's my thinking.
I would see absolutely no reason to use anything but long-acting
Mhm.
agents, once daily long-acting
And
agents.
you don't worry
There's
about the night dip?
no, I do not worry about the night dip. I'm delighted to see the night dip.
No, but I mean, if they're having night dip at evening and you give them a blood pressure that works 24 hours, wouldn't that lower it even further during the night?
Yes, I mean, if you want to supplement, you're talking about supplementing now. In the US, if I asked a patient in the US to do a 24-hour monitoring a second time, they would probably punch me and say, you got to be crazy. I'm not wearing this thing at night.
Hmm.
I'll do it once for diagnosis, but I'm not doing it again. Now, when we get to wearable devices that are much less burdensome for the patient, and when they are proven to be clinically accurate, I'll be ecstatic because we'll then have a lot more information. It'll complicate our lives a little bit because we'll have a lot more information. But like you said, it'll give us a much better window on what's happening outside the office and what's happening at nighttime. So I hope I hope that day comes soon. It's not here yet.
You
But
said
at the
you,
moment, you're a much more thorough clinician than I am.
no, I'm
I
not that.
no, I'm comfortable with office accurate office blood pressure measurements supplemented by what I hope to be accurate home blood pressure measurement. I generally expect with a long-acting agent that it's going to give me good nighttime protection. And long-acting agents are going to work 24 hours a day. So and if somebody misses a dose, which they do, no matter what they're going to tell you, that we know from screening urines to see what metabolites are in there that people miss doses. If that happens, your chances of getting decent blood pressure control
Control.
are pretty good. If somebody is on a long-acting agent and they're taking that pretty continuously, they'll tend to have pretty good pressures throughout. So
Mhm.
I'm pretty comfortable with that.
Okay.
I sleep soundly at night, not worrying about it.
Yes. Ex Exercise is very good for heart health and for blood pressure and for many different
Absolutely.
health reasons.
Yeah. Yeah.
However, sometimes especially with high intensity or even moderate intensity, some hypertensive or borderline hypertension people will have very high surge in blood pressure. The systolic blood pressure will go to 180, 200, 220. We see that sometimes in the treadmill test. Is
Yeah.
that spike in blood pressure harmful and would cause endothelial damage or organ damage? And what do you recommend to those people?
Well, it can be. So we know, we have a lot of experience that people who go out to shovel snow in the winter, uh, they have sudden cardiac deaths. That happens every time. If you ask, I have, as I mentioned, I have two children. One is preventive
Cardiologist.
cardiologist at Hopkins. The other one is an interventional cardiologist. She and
Yes.
her husband, they're both in Boston, where we don't get any snow in New Orleans. We get hurricanes where we don't get snow, but
Oh,
they get snow. And every year when they get snow, there is something in the newspaper, the Boston Globe, and it says, five people died shoveling snow. So it happens. They go out and they get a sudden spike in blood pressure, and they just have a lot of other things going on. Their sympathetic system is up there. We see the same thing with runners. Jim Fixx was a very famous marathon runner in the US. He was very well known as somebody who was intensely oriented to physical activity. And he had a sudden death during a marathon. And then people said, "Oh, how could this happen? This guy was this says we shouldn't exercise because he had a sudden death." Well, it turns out, he had a family history that was really pretty sad. High cholesterols, high blood pressure, all risk factors. So when you do physical activity, you often see in people who have a sudden death that on average, those people are doing better. But there are individuals who get a spike in blood pressure and other things
yep.
with a sudden surge, and they have an immediate cardiac event. Now, so I say that's why we have clinicians. Clinicians, they can take care of the very small fraction of patients who are very complicated. That's what clinicians do best. People who have very complicated presentations and need very careful adjustment of how you manage them. That's where I think a clinician is really important. For the vast majority of people who are just like me, they have simple stuff. As I say, you could train anybody to take care of my blood pressure just based on an algorithm. I don't need that level of attention. I need careful blood pressure measurements. I need adjustment of my medications. I need to be encouraged and helped for things like lifestyle improvement, whether it's physical activity or it's diet or abstinence from alcohol, moderation at least, etc. Those are all important things. That doesn't need the level of a clinician with their level of training. The type of patient you're talking about with spikes during a treadmill, that's somebody that should be managed by the clinician. That's a complicated patient, and you need to come up with
Maybe it's more
nuance.
common. Maybe it's more common, but people don't realize. So anyone would have baseline of 130, let's say. If he exercise and if he has white coat hypertension or it would surge just from talking, then for
They'll
sure it
tolerate
will.
it fine.
Yeah.
Yes, I can guarantee you that people have surges. I can guarantee you that just random variation, if you monitor somebody's blood pressure, you would be shocked to see how high it goes.
Yes.
It's very common to get to high pressures, but we tolerate it very well. Our
Hmm.
bodies adapt very well. They can tolerate very low pressures. They can tolerate high pressures. That's very common and very typical. For the person who has a lot of vascular disease underlying that, that's where you can get in trouble.
Hmm.
So I think I would say again, for the more complicated patients, that's where a clinician comes in and adjusting and modifying and giving nuanced recommendations and monitoring very carefully is very important. For the more typical person who has run-of-the-mill high blood pressure, high cholesterol, who is overweight and has typical diabetes. Diabetes, in most people is weight related. I have a nephew who's very young. He's 8, and he suddenly showed up out of the blue with type 1 diabetes. Well, that's different. But for the average adult, it's the explanation for their diabetes is not at all surprising. And what worked best in trials, the Diabetes Prevention Project, the DPP, is a very classic trial that randomized people to three possibilities. One was a lifestyle approach where they try to reduce weight and improve physical activity. And weight loss is really a combination of diet and physical activity. Diet is more important in terms of calorie reduction than physical activity, but physical activity has special attributes, as you mentioned. So that was one arm. Another arm was getting metformin, and the third arm was getting placebo. And the outcome was prevention of diabetes. So these were people at high risk for development of diabetes. Which arm do you think won?
Say again the arms.
Wait,
There was one
so
group with
three.
diet reduction,
One
one with
group,
X.
one group got lifestyle approaches. They got counsel for weight loss and physical activity. Diet and physical activity
Hmm.
basically is what they got. Another arm got metformin, and the other arm got placebo.
The physical activity and reducing those ones.
Correct. Yes, it beat metformin hands down.
Yes,
It wasn't even close.
yes.
Now, metformin was better than placebo for sure. But my point is,
You can do a
you
lot with
know,
lifestyle.
you can do a lot with lifestyle, and you don't have to be a very highly trained clinician to be able to do that.
Yes.
You need to be somebody who understands the basic rudiments to help people to
If,
overcome the challenges. And they are real and they are serious and they are very difficult because every time we look around, we have the means and we have the opportunity to eat and to eat badly.
yes,
And I say for the fast food places, they're fantastic in everything they do except the product. They're cheap, they're clean, the service is fantastic. It's a good ambience. They're everywhere when you need them. You
and
get
fun.
immediate satisfaction because you're getting a huge load of salt and saturated fat.
Yes,
The only problem is it's a terrible atherosclerotic diet.
yes,
So we're exposed to that. We're exposed to all the ads of, very attractive looking people selling things that are not going to make you look attractive, but they're selling it. So there is definitely a need for it. But most high blood pressure, most high cholesterol, most obesity can be managed just as well by a well-trained person who is non-clinician than by a clinician.
yes,
The clinicians are very important for people who have more complicated
yes,
presentations.
yes. Even the
That's
people,
my that's my
yes.
opinion.
Yeah, even the people themselves, like in a way that most people will know what is really bad for them in terms of diet, in terms of that they have to exercise. So
Yeah,
in a way,
but
the bad
but they
thing,
need help. They need
yes,
help. We know
yes,
that people have good intentions, and you're absolutely right. I was shocked one time when my I used to go to the school, a bit of Father's Day. What does your father do? And I remember going to my son's school when he was about 3 or 5, and I asked the class, anyone know what the risk factors for heart attack are? Well, every hand went up. They all knew. They told me that these were 3 or 5 year olds. They
yes,
told me diet, physical activity,
yes,
smoking. I thought I should resign my job because these kids knew at 3 to 5. So they knew what was right. The challenge is doing what's right.
yes,
And that does need a lot of help. So there's very little attention to things like high blood pressure, and it's easier with cholesterol because it's a very simple pill. Blood pressure is more complicated. You got to measure the blood pressure. You don't have a lab to do it for you, and it's more complicated.
Y-
So yes, we're not doing anywhere close to what we should be doing. High blood pressure is the most important risk factor for cardiovascular disease. Its treatment is incredibly well proven. It is incredibly cost effective. It is what WHO would call a best buy. And yet, all over the world, we're doing miserably. We're doing horribly. When we looked even at the 140 over 90 in our most recent global estimate at 220, what did we find? Well, we found in middle and low income countries, the vast majority of people were not even aware that they had high blood pressure. That's over half of the people. That was about 54%. Another roughly 15% were aware but were not even being treated. Another roughly 17%, they were being treated, but they were being treated very poorly. They weren't even getting to 140/90, which is not what any guideline would recommend. So we ended up that only less than 14% of people in middle and low income countries were even getting to less than 140/90. A little better in the high income countries, about 40% were getting to below 140/90, but that's still shocking. It's an indictment of high income countries where we have the money, we should have the desire, we should have the willpower. Our biggest cost item is cardiovascular disease. So, you look at it and you say, this doesn't make any sense. You know what your biggest social complication is. You know what your biggest cardio morbidity and mortality is. You know what your biggest cost item is. You know how to manage it, and yet you're not doing it. And the reason is you don't see the benefits of the treatment for maybe 2, 3, 4 decades,
Mhm.
as opposed to managing people to keep them out of hospital with heart failure. You
Yeah.
see the economic benefits almost immediately.
Yeah. But even with
So
tell me, sorry, go on.
go ahead. I was going to say we have a lot of work to do.
Yes.
We're making progress incrementally. Every time we do these surveys, we see progress, but it is at a glacial speed. I mean, we should be moving much faster. I will just say that I am very, what should I say? I am very excited right now. WHO took on this issue, about 10 or 15 years ago. And the World Hypertension League and many others tried to advise WHO as best as we could, and they put together a program called HEARTS, and it incorporates many of the elements that are effective for managing high blood pressure. It certainly includes things like lifestyle and risk-based management and accurate blood pressure measurements, providing care in convenient settings with team approaches. And it includes getting the medications to people in effective medications in affordable fashion and giving them recommendations for the dual combinations to use and monitoring them to see that it's happening. So that approach is occurring. In the Americas where I live, we have PAHO, the Pan American Health Organization. It's the regional manifestation of WHO. We're in about 33 countries with hearts. So that's a big initiative, and many people are supporting it. And there's a big financial support coming from a group called Resolve to Save Lives that Tom Frieden and colleagues are heading up. So I feel good about that. There are things happening now that never happened earlier in my career, but there's a lot of work to be done. And we know the pathway, and there are just a lot of impediments to that pathway. And unfortunately, we understand the impediments. We can explain them. They occur at every level. They occur at the patient level with patients either not understanding or not being able to afford the medications or get access to the medications. Many countries, they tell you, oh, the blood pressure medications in our country are free to everyone. The government provides them free. But then you find when you dig under the hood, yeah, they may be free, but they're not easily available. You have to go to a pharmacy, and the pharmacy says, we don't have that medication at the moment. Come back in a couple of weeks, or I'll give you a different medication. Anyway, there are lots of problems at the patient level. There are lots of problems at the clinician level. The clinician is overburdened, they're doing other things. There's huge therapeutic inertia where they start with something and they don't really change much. And then there are lots of problems with the setting in which we practice, whether it's a system of care or whatever. There are huge impediments. It's just set up to make our life challenging or miserable, if you will. It makes doing good care very difficult. They're everything you could imagine. They don't invest in the right equipment. They don't have accurate, clinically valid equipment. They don't train people. Many countries still have first come, first served. I won't mention it, but I work in a country right now where it reminds me of the US in the 1960s and 1970s, where you show up in the morning in the public clinic, which is the clinic that provides most of the care, and you get a number. And it doesn't matter whether you've been scheduled for an 8 o'clock or a 9 o'clock. And when they're ready, they'll take you. And if they're not ready during the day, they'll say, come back tomorrow. So that's happening in a lot of countries still. So there are lots of impediments there. And then when it comes to the insurer, which is often the government, they're just not focused on blood pressure as an issue. They will give you lip service to it every time you meet. Yes, we're very, very interested. But the reality is they're not that
Yes.
focused on it.
Good thing at
There are
least.
impediments everywhere. We can overcome them. We know how to overcome
Good
them.
thing about hypertension is not very difficult, at least to take charge of it yourself, because you can just buy a machine from a pharmacy and measure it yourself. Or
And that's the most important part of home blood pressure measurement. It's not so much me getting the measures from home. That's useful, but not much more important is engaging the patient in their own care.
yes,
When you get a patient to get a home and a clinically valid home blood pressure measurement and get trained, preferably trained and certified through the WHL's PAHO site or some other way, they become very engaged in their own care and those around them, their spouse, their children, their grandchildren, their buddies. These are all part of the network, the social network that supports people.
yes.
That really helps.
Now you were referring to 140 over 90. That is an office reading. What if someone has office reading 140 over 90, but at home is 130 over 80 on average? In the
I
US, would
would
you medicate that person?
I would be very interested in knowing how confident I am in those home blood pressure measurements. Do I feel this person has a valid measurement device? Do I feel that they have trained themselves or been trained to take an accurate blood pressure measurement? And are they getting an accurate blood pressure measurement? So it's a little out of my control because here I'm in the office. I know what I do in the office. The home one is, a little out of my control. If I was confident in it, I would say, yes, on average, they're 130 over 80. For me in the US, that's hitting our already hitting what we would call hypertension, where we would say if somebody has that level of blood pressure, for sure I would be counseling them in non-pharmacological approaches. If they have a high cardiovascular risk. So if I look at that person and they have high blood pressure, 130 over 80, and they also have either diabetes or they have kidney disease or they are older, let's say they're 65 or older, I'm confident they're at high risk. I don't need any risk calculator. Anyone who is older with that level of blood pressure is very, very, very likely to be at high cardiovascular risk. Somebody who has diabetes is likely to be at high cardiovascular risk, and on average, they become high about 12 years earlier than the rest of the population. Somebody with kidney disease is also very likely to be at high risk if they have that level of blood pressure, and that's going to occur about 7 years earlier. So they not only have the high risk, but they have more life exposed to high risk. So I am going to err on the side of treatment rather than non-treatment, especially if I see they have other cardiovascular risk factors. Now, if they don't have diabetes or they don't have kidney disease and they're under the age of, say, 60, 65, I'm going to use a risk calculator. And in the US, unfortunately, risk calculators, unlike measuring blood pressure, which is the same in every country, risk calculators are based on cohorts and they are very country specific. Something that works well in the US or Europe doesn't necessarily work well in Saudi Arabia or in UAE. So it's a bit challenging, but
Mhm.
you do the best you can. And so, at least for me, I will use a risk calculator. The one we currently use in the US is called Prevent.
Mhm.
It's similar to what we used before, but it's based on more current cohorts, a much larger database, inclusion of a wider array of people of race ethnicity than previously. It has heart failure as an outcome, which we didn't have the previous ones, which is really important if you're dealing with blood pressure. So I will use that one. And if they're at high risk, for sure I'm going to treat them. If they're not at high risk, then I'm probably going to follow them with non-pharm approaches, see how they do. If their pressure remains, in the 130, 80 range, even with non-pharm counseling, I'll probably add in a single medication after 3 to 6 years. That's what our guideline would recommend.
Mhm.
So we tend to err on the side of trying to get the risk down because we think the risk is minimal. The benefit is not as great as if you were bringing the pressure from 160 to 140, but it's still there. And people are going to live a lifetime. And
Mhm.
our risk predictors underestimate.
Mhm.
So I think if you're ever worrying about whether to treat or not to treat, on balance, I'm going to tend to want to treat because the treatments are relatively inexpensive, very few side effects. Getting to lower pressure is always beneficial, and even lower than what we recommend in guidelines is probably beneficial. In the guidelines, we tend to be science-based, so we want to look at the clinical trials. What has been proven? Well, okay, 120, 130 has been proven. Is it likely that getting below that is beneficial? Sure.
Do you give any value to the surgeons? Let's say the first reading, someone comes trying to catch his appointment, sit down,
Yep.
and his blood pressure is 160. Do you give any value to that reading that is too high, or you don't even consider it?
I give a little, not too much, because I will say we've looked at variation in blood pressure. We know it's there. I mean, you don't have to be a rocket science to recognize it. Any
And
any clinician knows
do you
one
believe that
pressure to
causes
the other.
damage, not as a from research or a study, personal
I
from your
I think
experience?
short term and looking at variability in blood pressure, in other words, spiking up and spiking down, if you will. We've looked at that. We've looked at that in lots of cohorts, and statistically, it is associated with cardiovascular risk
Hmm.
in almost all cohorts. So there are a lot of papers written on the relationship between blood pressure variability and cardiovascular risk.
The
So it's
the
there.
variability itself,
Correct.
not just the
Now,
surges.
correct. When you look at how important is that clinically, when you look at risk prediction and you take all of the standard risk predictors we have, average blood pressure, cholesterol, etc., and you add in that variability in blood pressure, it has very little additional impact. So maybe 2 to 3% is what I've found in my own what should I say investigations.
Hmm.
So I'm not saying it doesn't exist. It does exist. If you're talking about short-term spikes that are sort of more biologically oriented, yeah, there's something there. But I'm still gonna go back and say the main thing is average level blood pressure.
And would medication correct these variabilities and surges?
That's a very good question, and we don't really know which medication class is best. There have been people who have said calcium channel blockers might be better than others for
Mhm.
reducing variability. There are others who have different opinions. Probably the most common class that would be recommended for reducing variability is CCB, but it's not well proven. We don't have good information on that. We don't even know that by reducing blood pressure variability, you're going to get a beneficial outcome.
Mhm.
You might expect it from the observational data, but we don't have clinical trials to prove it. So a lot of speculative
But if
stuff.
you don't want to,
On,
if you're in a gray zone where you don't want to treat, that could be additional risk factor to push you towards
it could.
treatment.
It could. It could. I would say, it's the old dictum, common things commonly occur. So Yeah, average level of blood pressure is without question very big in its impact. I mean, that's well proven, not only observationally, but in clinical trials. So I'm going to put my money on that one and put most of my effort there. Are there other things around the margins I might take some notice of? Yes. Am I going to put most of my focus on that? No, no,
Mhm.
I'm not. I'm
Mhm.
not. Now, again, we're talking about different patients, and somebody who is my age who has had a heart attack or a stroke or, is a complicated person, I'm going to say, okay, Mrs. Doctor, or Mrs. or Mr. Doctor, please look at this person carefully. This is
Yeah.
a complicated patient. They have some decrement in renal function. They certainly have had vascular disease. We know if it's in one organ, it's in the other organ. So this is one you need to manage with your best clinical instincts and training. For the other people who come in, even if they're older, I will say, okay, let your team that you have trained and follows a logical algorithm do most of what's there. Supervise them. If they have a problem, let them come talk to you and so on. But they can manage most of those people very, very well. And that's where most of the benefit is going to occur.
Yes. Yes.
It's not the unusual patient, it is the common is the problem. We're not recognizing and treating high blood pressure in a common sense.
What are your thoughts about strength exercise for hypertension? Strengthening um,
Yeah.
l- body weights or
all, all
lifting weights?
form all forms of physical activity lower blood pressure. It's
Yes.
we started our general recommendation has been aerobic exercise where you're brisk walking or running or dancing or swimming or all those sorts of things where you're moving around, you're moving the joints and the muscles. That's aerobic exercise. Core recommendation has always been aerobic, and we say basically moderate intensity, about 150 minutes per week.
Per week. Yeah.
High intensity, if you're really running and I don't do that. I walk briskly, but if you're like my children, they run. We say more intense exercise, 90 minutes a week. So whatever combination of those you're using, that's what we recommend. No, that's just a recommendation. Any physical activity is good. Then we go to the next level. We say, okay, what about
Isometric.
isometric
Yeah.
resistance exercise? This is where you are moving, you're doing
Or squat on
push-ups,
the wall.
push-ups,
Mhm.
push-ups, pull-ups. You've got weights, you're moving them up and down. It's what you'd call strength exercise. That's good. That lowers blood pressure as well. And we often, people will often do some combination. They'll do aerobic for most of the week, and then they might do 1 or 2 days of isometric resistance. The third common type of exercise is isometric
Yes. Exercise where you hold yourself
static. Yeah, where
squat
you're, where
on the
you're
wall or
exactly where
plank. Yep.
you're not moving the
Muscles.
joints.
Yep.
And that would be yoga poses or wall planks or even a hand grip where you're gripping it and you're holding the grip.
Yep.
Now, I personally wouldn't have thought that would do much, and the trials in that sector are not as good as the trials for, say, aerobic, and there are not as many of them. Aerobic has the most trials by far.
Yeah.
But shockingly, in several recent meta-analysis, the biggest reduction in blood pressure has been with isometric
Yes.
resistance, where you're not moving the joints. It's surprising to me. I don't understand it, but the data generally don't lie. And I will just say the data here are not as solid. The trials aren't as good. But it looks to me like all forms of physical activity are good for you.
And what
And
about
we know,
meditation and yoga?
yes, that is basically isometric exercise where you're not moving the joints. You're just doing poses.
Hmm.
Now, I will say, going back to aerobic exercise, we now know there are tons of trials that have shown us this, that even the people who are so-called weekend warriors, during the week they're in front of laptops or screens or they're busy with their jobs, and then come Saturday and Sunday, they're beating the hell out of the place. They're down in the exercise room or they're running like heck. That does, for the equivalent exercise, just as much good as people who have their exercise distributed equally throughout the week.
So the total of
Interesting.
the week. Yep.
Surprising to me. I would have expected, that those who do it on a regular basis would do better, but we have lots of comparisons of those two now, and the data is in. It's very clear that weekend warriors get a lot of benefit from their form of physical activity. So I say all forms of physical activity are good, and not just blood pressure, of course. It benefits
Overall health.
many other risk factors for cardiovascular disease. So observationally, you see striking relationships between level of physical activity and outcome.
Is
And of course, you see this so-called fit-fat paradox. So people who are fat generally have high risk, but it's particularly when they're fat around the abdomen. And men tend to have that. Women tend to have their fat around the hips. They're pear-shaped, and men have apple-shaped.
yes.
And when we look at people who are fat but fit, they don't have the same level of cardiovascular risk as people who are fat but unfit.
Mhm.
So the fitness is very beneficial even in people who are grossly overweight. So that's an interesting finding and one that's, again, very well proven.
Is there any evidence that high intensity, is there any clinical trial where high intensity was done in hypertensive population? And did it lead to positive results?
Oh, yes. Oh,
Mhm.
absolutely, yes. We have tons of trials of physical activity
High
for lowering
intensity
blood
training.
pressure. Both moderate, which is more realistic for most people, and was what we generally recommend because most people will not continue for a lifetime with high intensity. But we've got trials in high intensity, and,
Would,
and high intensity will be very effective. In fact, high intensity will do more good in the short term, but it's hard to maintain that lifestyle over a period of time.
do you
The things are
get
repeat
concerned with
if
the
you
spike of blood pressure for high intensity with someone with hypertension, or you would just, because that's
uh,
what will happen if someone is hypertensive and they
I
put the
think
heart rate to 180 beats per minute, for sure the
I,
systolic will shoot up.
yeah, yeah. I think in somebody who has underlying cardiovascular disease or is likely to have underlying cardiovascular disease, then that's where a clinician is very important. That I think if you think somebody has ischemia or is potential for ischemia, then you might be a lot more
If
careful
someone is young
in.
and healthy and he has this
Someone is
spike,
young and healthy, go ahead and beat the heck out of the treadmill.
yes,
So now, unfortunately, I live in a country we celebrate Christmas, so and New Year, and every New Year, every company that has the commercial physical activity places or fitness areas, they are advertising like the Dickens. They want people to sign up because they know that most people are going to sign up. They're going to take some some arrangement, some seasonality, either an annual membership or you try it for 3 months, and if you don't like it, and so they're going to get money out of people, and they know most people are going to show up for one or two times at their fitness center, and then they're not going to show up anymore. So that type of approach to physical activity for most people is not well maintained. It's not a good recommendation.
hmm
I'm not saying it's not good. It's great if somebody wants to do it and they will do it. And for the motivated person, it's fantastic. For the average person, it's much better to say, find a place where you're happy, And if you're not a loner, I do physical activity on my own. I listen to classical music. I go out late afternoons or early evenings, and I have my
Earphones.
earbuds in, and I listen to classical music, and I like to be on my own, and I think about the day and so on. Most people are not like me. They like the social interaction. So if you can, if you're like most people, going out and doing brisk walking with a friend, where you're still able to talk, but you're sort of doing it in a place where you're happy. If you're in an inner city in the U.S., it's not necessarily safe to go out in the neighborhood. So you go to a mall, you go somewhere that's safe and has a long track for walking. I like to walk in my neighborhood. I live in a very safe neighborhood, so it's different architecture. I have a big park just next to me. I don't use it much. My wife uses it, but
Mhm.
I prefer walking in the neighborhood. It's more interesting to me, and I
Yes.
sort of know exactly how many steps I get with each component of my walk. So it's very predictable for me. I shoot every day to get at least 10,000. I typically get 13, 14,000 steps a day. That's
Very
just
good.
me.
That's a lot.
But whatever works for the individual, that's where I think sitting down with an individual, trying to understand their lifestyle, their life, and what is realistic for them. What do they want to do? If they tell you, I already exercise in the exercise room daily, you say, fantastic, keep it up. Do a little more if you can.
Yes. Do you
But for
recommend
the average person,
fasting for people with hypertension, or are there any
no,
beneficial evidence? No?
no, no. I have no knowledge of any benefits. I'm not saying there couldn't be, but I do recommend weight loss. Yeah, for me,
This
I'm
specifically for
trying,
hypertension, or generally you don't like fasting? Or you have no
generally,
mhm.
generally people who fast tend to rebound and eat more when they stop their fast.
Yes.
So I think, trying to lose weight, try all the right things for physical activity, the things that are best proven. There's a long list, but of the things that are best proven, we know what they are. Weight loss if you're overweight, getting a healthy diet, and there are lots of healthy diets. And Mediterranean diet is healthy. We use a DASH diet in the U.S. It's a heart healthy diet. There are a low fat, low carb. There are tons of heart healthy diets. Any heart healthy diet is going to lower blood pressure,
Unprocessed food
guaranteed.
generally.
Unprocessed foods, so a healthy diet, absolutely, yes. Reducing sodium intake. We tend to eat a lot of sodium,
Yeah.
and it's not natural in foods, it's through processing. Enhancing potassium intake and reducing sodium will, to some extent, change the diet pattern to get more potassium, but potassium on its own is a very useful agent for lowering pressure.
As a diet,
And then
right?
pardon?
From the diet, the potassium, or even
Better
supplement you would
from
recommend?
better from the diet. The trials mostly have used supplements. We've used diet and supplements. The majority of the trials have used supplements. Both supplements and dietary approaches have worked. Supplements are easier. So if somebody is not going to be easily able to follow a diet, I have no hesitation in giving them supplements.
Mhm.
They're safe, they're effective, they're good.
And what should they
Physical
aim for the
activity,
dose of potassium supplement? And what
well,
type of potassium also?
yeah, probably based on, I've done a lot of dose response meta-analysis. For almost all of these lifestyle approaches, it's linear. So we have a recommendation, but any change in a beneficial direction is useful.
Yeah.
For potassium, it's the one that is a bit peculiar. We kind of see a U-shaped curve. And we're not sure about it because we don't have that many trials at the extreme of lower and higher intakes. But based on what we've seen, a supplement of about 30 millimoles per day may be optimal. Any increases is an improvement. A supplement of about 30 millimoles per day in most communities will get you about 90 millimoles of intake because we're already eating
Eating, yeah.
potassium in our diet. But certainly supplementing to a modest extent, is good. We talked about physical activity and then alcohol, either abstinence or at least moderation. I am in a Western society. I like to have a Sazerac. If I pour a Sazerac, it's going to be, I live in New Orleans. We're a party town. It's a very generous pour. I just have to give it up. I'm trying to lose weight at the moment. I gained a little weight, so no alcohol for me. I know that that's going to help me with getting my pressures down. So, at the moment, what am I doing? Well, of course, doing physical activity. I'm pretty careful on my diet, but I am further limiting my diet to be even more careful. No alcohol.
Yes.
I need to lose weight. And I can guarantee you I will lose weight. I won't lose it as quickly as when I was younger. When I was younger, I could lose weight very quickly.
Yes.
Now that I'm older, my metabolic system is slower. So it is easier to gain weight because my metabolic system is lower, and it's harder to lose weight. But I can still lose weight. And I can tell you, I started this maybe, I don't know, a month or 2 months ago. I had to go on some trips. Always when I go on trips, my diet is crazy because
All
I'm
of
on
us.
planes. Yeah. But I'm back on straight and narrow. I've lost around 20 pounds. I want
Oh,
to
very
go.
good. Congratulations.
Well, thank you. I need to go at least 5 pounds. I know what to do. It's just having the willpower to do what I know I should be doing.
Yes. Any thoughts on heat therapy such as sauna for hypertension?
Well, well, clearly blood pressure is affected by temperature. There's no question about that. For people who live in situations where there are extremes of temperature,
Yes.
especially if they don't have heating or air conditioning. So if there are extremes of temperature and they're really exposed to those extremes. Now, I live in the US, so I live here in New Orleans in the deep south near the Gulf of America. Our feel like temperatures at the moment are about 43 to 45 centigrade. So it's hot.
Yeah.
And our big problem is we have high heat, but our bigger problem is we have very high humidity because we live next to the Gulf. So it saps your energy. So no question, for people who would not have good air conditioning, they would be exposed to that extreme of heat. Now, in the US, every house has air conditioning, every car has air conditioning. I have a swimming pool, and most people in New Orleans have swimming pools because that's where we live. So it doesn't apply as well as it would in a country where people are exposed either to the extreme cold of winter or the extreme heat of summer. But if you are exposed to those extremes, clearly blood pressure will be much higher in the wintertime and it'll be much lower in the summertime. And clinicians in those settings have typically adjusted the blood pressure medications
So
from
it's a
summer to
negative
winter.
impact. If someone goes to the sauna or steam room or gets exposed to the sun in a very high temperature, but then would go home at normal temperature, that's a negative impact from heat?
Well, if you're exposed to heat, your vessels will tend to vasodilate,
Hmm.
no matter how, whether it's the sun or it's a sauna.
On a
Uh,
long
anytime,
term,
anytime you're exposed to heat, people who work in foundries um, are exposed to heat, their pressures are going to be lower
hmm,
during the heat exposure. Now, most people live in bubbles. We live in an air-conditioned home and we have air-conditioned cars, and that's the way most of the world is going these days. So we don't really get exposed to those extremes of temperature. We go to the doctor's office and there's air conditioning. We're in our car, we're air conditioned. We're in our home or apartment and it's air conditioned. So we may talk about extremes of temperature, but we are not experiencing those extremes of temperature.
what I
But if
meant
you
is
are,
what
if
I
you
meant is
are
sauna, for
exposed,
example. If you goes 10 minutes, that will have positive long-term effect or negative long-term
no,
effect on
no,
blood pressure.
no, it will have short-term effect. As long as your body is hot, your vessels are going to vasodilate. If you were to go to hospital, I used to bring people when in the old days when I started, we didn't have such good medications. I had a lot of people with really high pressures, what we call malignant hypertension at the time. And I collected a group of about 300 people with renovascular disease. And when their pressures were really high, we would bring them in the hospital and you put them at bed rest. And guess what? Magical. Within about 3 days, their pressures were down. Sometimes we had to stop their medications or at least modify them dramatically because their pressures just crashed at bed rest. So, yeah, but once they went back out into the community, their pressures went up again. So, yeah, some things will have predictable effects on blood pressure in the short term. Temperature is one of them. A high temperature will result in a higher pressure. Excuse me, a low temperature if it's intense. If it's intensity, if you live in Nepal or somewhere like that where you get a lot of cold weather and snow and so on, yes, during that cold period, your measured pressures, if you're exposed to those cold temperatures, will be much higher. If you live in New Orleans and you don't have air conditioning in the summers, your pressure is going to be lower. And
Yes.
people who live at high altitude have higher pressures,
Hmm.
especially those who move from a lower altitude to a higher altitude rapidly. If you helicopter from a low altitude and you're dropped off at a high altitude, your pressure when you get off on that high altitude is almost certainly going to be higher. There's a lot of good information in that. My good colleague, I'm the immediate past president of the World Hypertension League. My good colleague Gianfranco Parati, who is the current president, has done an enormous amount of work on that in the Himalayas and in South America and the Andes. And he's shown a lot of physiological changes between high altitude and low altitude,
Hmm.
including higher pressures and high altitude.
Yes.
So there are things that do have impact. There are things like particulate matter that has impact. It has big impact in some countries where there is a lot of exposure to air pollution. In a country like the US, we can show a relationship statistically, but it's not a big factor. We don't put it on our list of risk factors for blood pressure. So the list that we put in our guidelines are the ones that are the most important and the ones that have been proven with clinical trials. When we change the exposure, we get benefit. Those are the ones that are in there. And they're the ones I mentioned. There are other ones that are, most people will often in a guideline will put in reduction of stress. Nobody wants stress. Reducing stress is a good thing. The evidence that stress reduction lowers blood pressure is not good.
Really?
Um, it's not well proven. So I say I have no objection to putting it in because I don't wish stress on anybody. But don't muddle up stress reduction with changing your diet or um, not taking alcohol or being physically activity. Though physically active, those things are very well proven.
Yes.
Whereas
Yes.
the stress reduction, it's not desirable, but it's not well proven that it would reduce your blood pressure. There are a lot of other things that are associated with blood pressure as well that we generally don't make recommendations on because they're not major, they're not top of the mind for most people.
Mhm.
If you live in high altitude area, things are a little different. If you live in an area where day to day you're exposed to these big variations in blood pressure, it's different. If you live in an area where there's a lot of pollution, yes, it's different.
Yes.
Some of the solutions are challenging. How do you
Out of your
change
control.
your
Yep.
some of them are out of your unless you move. If you're in
Yeah.
a high
Environmental
pollution
toxins
area,
also.
yep. The only solution, which is not a good one for most people, is moving to another area.
Yes, I believe environmental toxins are driving a lot of diseases, including degenerative disease and dementia, because the nose has no filter. It just goes to the bloodstream, unlike the
Yeah,
stomach. But how can you prove that?
yeah, 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 yeah,
Or
yeah.
anything you believe that we didn't talk about in this interview, or anything important that you would like to
I
address?
think No, I think we covered the main issues, and it's been a delight talking with you. And my hope is that we will continue to see improvements, but we'll see them at a faster pace than we've been seeing them. We know the problem. We understand it very well. The science base for blood pressure is phenomenal compared to many other areas in medicine. So we know the problem. We know how to address it. And now our focus in research and blood pressure for people like me is primarily looking at implementation. How do we go from knowing what to do and actually having it done in practice? It's a fascinating area, and there is a huge chasm between knowing what to do and doing it.
Implementation.
And a great example of that, probably the best examples, the most shocking examples are in trials. So we've seen this many times in trials, and we saw it again in sprint. In sprint, we of course had two arms. One arm was the intensive treatment arm, the other was standard treatment. In the intensive treatment arm, we were advising the clinicians. It was clinicians in practice who were taking care of patients. We were helping them. We were advising them what combinations to use, et cetera, et cetera, et cetera. And during the trial, we got these great blood pressure reductions. By the end of the trial, it stopped early for benefit. Well, the clinicians taking care of those patients in the intensive arm, they knew exactly the results of the trial. They knew. We had lots of conversations with them. They saw our publications that lower is better. In fact, the patients knew. We communicated directly with the patients, so they all knew what was desirable. So you would think, okay, after this trial, what should happen is the group that were getting standard treatment will now be treated more intensively and their pressures will come down. And at a minimum, the group that were being intensively treated will continue in intensive treatment. Well, we were told, trial is over, stop advising, leave the scene. We continued to follow the pressures using electronic health records. And what did we see? Well, we saw what we see in many other trials. The group that had been standard care, their pressures continued about the same, no better. They didn't get any lowering of blood pressure. The group that had been more intensively treated, their pressures went right back up to where the standard care group was. And guess what happened to the hazard ratio for cardiovascular disease? It followed blood pressure. It went right back up. Shocking. I mean, and you say, how could this possibly happen? These were clinicians and patients who knew the benefit of more intensive treatment.
Mm-hmm.
If it's happening with that group, my God, what's happening in routine practice? So
Yes, these are
it tells
proofs.
you that there is a huge difference between the science base and what we know should happen and the practical realities of day-to-day care in clinical settings where you have a lot of pressures, you have financial incentives, you have what is acceptable to your peers, what is acceptable to the payer, in this case, in our country, CMS and the private insurers, what you're rewarded for, what you're publicly humiliated by or financially penalized by. So we have a big disconnect. So that's what we have to overcome. Not easy. And that's a lot of the focus I have right now in my research is trying to see the ways we can improve implementation. And that's what Hearts is all about and what many other approaches are about. So it's an interesting and I think very exciting time where we're on the right pathway, but we need to accelerate the changes in clinical practice. So I think I've been involved in guidelines for years, and I've chaired many guidelines, both in the U.S. I chaired the first primary prevention of hypertension guidelines. I chaired the 2017 ACCHA.
Yes.
I've been involved with the WHO guidelines and other guidelines. So I think the guidelines are really good in terms of looking at the science and there are recommendations, generally speaking, in the better guidelines, the ones that are really done well. Their science is very good. I mean, there are differences between these guidelines, but they're generally very similar. They're much more alike than they are different.
Yes.
All the core issues of diagnosis and how to manage and what level of blood pressure management, we're pretty darn similar. We have some differences in cut points for diagnosis, but we're more similar. Our challenge with these guidelines is they don't have any impact. They're written, they're wonderful, they generally are comprehensive, so they're very long. We do our best to write every segment or every chapter in the same fashion. Everything is the same, so you can go in to the index and say, I want to know about managing high blood pressure in people with prior stroke or people with heart failure and so on. And you're able to go in, and the format is identical from one segment to the other. So we do our best. We put in executive summaries. We write a lot of supplementary papers with the core stuff, but they're generally ignored. So that's the challenge. Our guidelines are generally pretty solid in what they recommend, and they're pretty generally ignored by the practicing community. And you'd have to say, why? Are we doing the guidelines the wrong way? I had a feeling always, or certainly in the recent past, that maybe what we should be doing is coming out with a one page that says, here are the top 5 or 10 things, do this, and then supplementing that with all of the details. Well, in our guidelines, we generally have a top 10. We'll have in there what are the top 10 things you should be doing, but it gets lost in the bigger picture of the
Yes.
guideline. So I wrote a paper with some colleagues right now. It's under review, and it is again looking at what are some out of the ordinary, or what we call out of the box thoughts about how we might simplify our recommendations and do better, make it easier for clinicians. And I think we're going to get there. We all recognize now that the guidelines are wonderful, but not having impact. So everyone is struggling now with how do we make these guidelines more effective?
Yeah.
And that discussion is clearly very active. It's been active. I got together after the 2017 guidelines with my colleague who chaired the European guideline, the ESC, Brian Williams. We wrote a piece in JAMA, and basically titled it More Similar Than Different. And then we got asked by our parent organizations, the American College of Cardiology, American Heart Association, European Society of Cardiology, to write a paper that was jointly published in Circulation, JACC, and European Heart Journal on how to harmonize these guidelines. And we were all in agreement. The scientists are all in agreement. We recommended ways to try to bring these guidelines together, if not have one guideline, at least have harmony in what we were recommending. But what actually happened? Well, in Europe, they split apart. ESC and ESH went their separate ways and put out 2 guidelines instead of one. Nobody harmonized with the other guidelines. So there are a lot of factors for our organizations. They like a new guideline. It draws people to a meeting. It gets people excited about their journal. We're going to be publishing the new guidelines in hypertension. They may be virtually identical to the former guidelines, but they're new. So, you've got to read these guidelines.
Yes.
So I think we understand some of the issues. We understand we're not having the impact we want to have, and we are working in different ways now to try to come up with recipes that will get us to a more accelerated improvement in the control of high blood pressure, better recognition, better management, better control.
Do you have any books, or where can people follow you and follow more of your work?
Yeah, they can follow me. They don't have to follow me, but they can follow me pretty easily. You can Google me. It's not hard these days. These days, I don't write so many books because people don't read books anymore.
But you were involved
But I
in
have
the recent guidelines, right, in 2025?
Yeah. Yes, yes. On the 2025 guidelines, we didn't make many changes from 2017.
Yeah.
2017 was pretty revolutionary.
Yes.
I got a lot of pushback from people who they don't like change. So, people don't like change. We like to say just as we were. So we got pushback. 2025, we made some changes, but not huge changes. Um, I write the I have written the hypertension chapter for some of the main textbooks. So I have the current chapter for Harrison's Internal Medicine.
Hmm.
I have the current chapter with colleagues in Fuster and Hurster, Fuster and Hurst, probably the most major cardiac textbook. And I have the current hypertension chapter with colleagues in Brenner and Rector, which is the main nephrology textbook. And those, I think, are pretty good encapsulations of what we would recommend. I especially, of course, like Harrison's because I wrote on my own and it's a shorter chapter, but it's not maybe quite as up to date as some of the things we talked about today, but it's generally going to be saying the same sorts of things. So those are areas, but anyone can find me with a Google. It's pretty darn easy, or if they want to be more sophisticated, they can go to GP chat, which is amazing. It's not always
Yes.
correct, but it is
Yes.
pretty darn amazing.
Yes.
What it can
It's
get
good
for you.
to collect information from it, but you have to make the judgment. Doesn't have the judgment
Yeah,
yet.
yeah.
Yeah.
Medline, of course, is going to have all of my publications. I've published maybe about 700 journal articles, and I've always tried as best as I can to be careful that I never want to put my name to something that I'm going to be unhappy about 20 or 30 years later. So I'm sure there must be some, but I can't think of a publication that I'm on that I've ever regretted 20 or 30 years later.
Yes. But
So I'm
you,
very careful. I'm very careful what I'll allow my name to go on. If my name is on it, I have read that paper very carefully, and not to say that I have necessarily been important to the paper, but I have never put my name on or allowed my name to go on a manuscript that I am not very familiar with and 100% comfortable with.
we did one of the most important trial, the sprint trial, and shared one of the most important revolutionary guideline in 2017. So we thank you for that, and we thank you for all of your service in hypertension and all of the knowledge and wisdom and teaching that you have spread across your career, and also what you shared with us today. So I thank you very much for sharing your time with
Thank
me and
you.
my audience.
I look forward to seeing you and Chala, and I maybe the next time we will meet in person.
Yes, we would love to have you again here, and would love to meet you in person as well. Hopefully, when
Thank you.
something new comes next time.
Thank you very much.
Thank you. Thank you so much.
Bye
Thank you.
bye.